Hello, micro friends. Welcome to another episode of Let's Talk Micro. As always, I am so happy that you're here with me. And if this is the first time you're listening to Let's Talk Micro, well, thank you for choosing it as one of your podcasts. Okay, and I know you want to learn more about rapid AST or fast AST, so we're going to jump into the episode, but before we do that, I just want to quickly say that this is the third episode on a partnership series of episodes with bioMérieux, a global innovator in infectious disease diagnostics. And on this third episode of the series, we dive into fast AST or antimicrobial susceptibility testing. And in the episode, I am joined by Dr. Sonali Kalathiya. She was a guest before on episode 172 from the Talking AMR series. So in this one, we dive into what is fast AST. We talked about the process, the impact it has. We talk about antimicrobial stewardship and more. So let's go ahead and listen to it. Hey, micro friends, welcome to the third episode in our special series in partnership with bioMérieux, a global innovator in infectious disease diagnostics. Before we jump into the episode, let me give you a quick overview of what we have done so far. In our first episode, we walked through the evolution of antimicrobial susceptibility testing, or AST, taking a historical look at where it began, where we are now, and where we're heading. Then in the second episode, we explore molecular diagnostics, bloodstream infections, and the impact of diagnostics on patient care. Today, we're diving into fast AST, comparing it to traditional methods, exploring how the technology works, and discussing its real-world impact. Our guest today is someone that, if you have been a long-time listener, you might remember her from our Talking AMR series, where she joined me and Andrea for the macrolides and lincosamides episode. So with me today, I have Dr. Sonali Kalathiya. Hey Sonali, welcome back to Let's Talk Micro.
Hi, Louise. How are you?
Pretty good, doing great. Thank you for taking some time to be here. Maybe for those that are new listeners, maybe you can start with a quick introduction about what you do and anything else that you want to share with them.
Sure. So my name is Sonali Kalathiya. I am an infectious disease pharmacist. I did my pharmacy school at University of Kentucky and my residency at Grady Health System in Atlanta. And I practiced for a few years in stewardship, and I'm now a medical advisor at bioMérieux.
Well, once again, it's great having you back. So let's go ahead and jump into the episode. Okay, so as we like to do here, we like to start with our basics and breaking things down. So for those that are unfamiliar, what exactly is fast AST and how does it differ from traditional AST methods?
Yeah, so traditional or conventional AST is phenotypic antimicrobial susceptibility testing that's performed on colonies, right? So you draw your blood culture, you load it onto a blood culture incubator, which monitors microbial growth and flags if it detects anything. And then once you pull it out, you can do gram stain, you plate it to grow colonies, and that's actually what you use to run your conventional AST. So this typically takes, anywhere from 24 to 48 hours, depending on your workflow from positive blood culture. And it's really what's widely used and considered standard of care at this time. In contrast to that, FAST AST is a phenotypic antimicrobial susceptibility test, but it's direct from positive blood culture. So, as soon as your blood culture flags as positive, you're able to run it on these platforms, and the turnaround time is typically less than 8 hours from the time of positive blood culture. So this is a really, novel technology that first became available in the U.S. market around 2017.
Okay, thank you for that. And for those of you listening, right? So if you're in this audience and you're, a microbiologist that you work in a lab, so basically all of us, we do the, traditional or conventional, pretty much. You might be exposed to some sort of rapid AST, but overall, you have different systems out there. And like Sonali said, right? So you get your plates from there. Once you have those isolated colonies, you set up your susceptibilities. And maybe you might be doing something when it comes with something rapid. And I have told the listeners before, like we used to have a validation where direct from blood culture, we'll set it up on the Vitek. And then from there, once, by the time we were reading plates, we'll compare, okay, I have the susceptibility, it looks good on the plate. good to go. I feel comfortable releasing this up there. Sometimes, maybe we're hearing things as we hear rapid AST, we hear fast AST, and there might be some confusion. Is there a difference between the two of those?
So generally speaking, they are really used interchangeably in the literature, referring to the same technology, this phenotypic AST that's performed directly from positive blood culture with, results within 8 hours. However, the FDA did historically reserve the use of rapid for AST systems that provide results within 30 minutes. So you might see that nuance there, but for general purposes, I think they're really used interchangeably.
Okay. Yeah, and that makes sense. Like, you think about things like when you're working on the lab and rapid strip and things like that, you get like the results provided in a short amount of time. So I get that. Okay, and then like you and I are, we have more exposure to this type of topics, so we might have a better understanding. But if someone is kind of walking into this and they want to understand more about what was the clinical need or the challenge that led to the development of fast AST.
Yeah, so I think it comes down to, sepsis, right? Sepsis is a life-threatening organ dysfunction that's caused by dysregulated response to infection, which can progress really rapidly, and so time is of the essence here. It carries a high mortality and morbidity rate, and we know that every hour delay in appropriate antimicrobial therapy increases mortality in sepsis. It's been shown that 1 in 5 patients receive inadequate antibiotic therapy. So there's this need for early broad spectrum antimicrobials in sepsis to adequately cover any potential pathogens that might be implicated there to improve patient outcomes. However, we know that we must balance this with unnecessary use of overly broad agents or for prolonged amounts of time to prevent antimicrobial resistance. And so this really highlights, the importance of quickly identifying what your causative pathogen is and then which antimicrobials are going to be effective against that specific pathogen that's in your patient to allow for appropriate escalation or de-escalation or whatever modifications that you need to make to really optimize your patient's therapy. And so, I was referring to conventional AST. So, again, that can take anywhere from 24 to 48 hours from positive blood culture. And so there's that, lag time before you have the answer. So fast AST is really hoping to close that gap a little bit and, give clinicians the results sooner so they can be making informed decisions for their patients.
So yes, and then and speaking of informed decisions, and we touched on the previous episode, right? So molecular testing, right? So that we talked about, and there's like genotypic testing, and how does this tie to this fast AST?
Yeah, so I think, I won't go into the details of rapid molecular testing. Definitely check out, part one to get into that. But there are rapid molecular tests that, along with rapid identification, can also detect various genes that are known to confer antimicrobial resistance. So when it's positive, this genotypic information can be very impactful. Help you inform both de-escalations and escalations in certain situations. But for gram-negative organisms, especially when it's negative, it can be really unclear. What's the most optimal therapy still because of the potential for other mechanisms of resistance that might not be detected on a molecular platform. And so that's why even rapid molecular tests are complementary to your phenotypic AST because you really need to have that in order to make a definitive decision for most of your patients.
Yes, and and very important when you detecting like like these genes that you see, and it changes therapy, and like we have mentioned and things like very difference between having like a KPC and an NDM and how that affects treatment, right? And the how NDM and the beta lactam. So it's the having that information. It's very important. Okay, so how does this approach fit into the larger evolution of antimicrobial susceptibility testing?
Yeah, great question. So we know that performance of these commercially available fast AST platforms is generally good compared to your conventional AST, which is great. The results are reliable. However, at this time, the panel menus are not all encompassing as our conventional AST panel menus are at this time. At this time, there's often a focus on gram-negative organisms, again, due to the complexity of resistance mechanisms that we've alluded to being less, predictable solely from the genotypic information, compared to gram-positives, where with rapid molecular tests of the resistance markers, that might be sufficient for you to make decisions in most cases for directing therapy. But there might be some gaps also in bug drug combinations that are FDA cleared for testing. That's based on performance of the test of that specific bug drug combination. And then also, organisms must be indicated on an antimicrobial's FDA package insert in order for the FDA to, allow gaining clearance of that combination. So that's another situation where your conventional AST test is needed. Um, and then there also might be situations where there's a bug drug combination that is FDA cleared, but it has a limitation where you still need to retest by an alternate method in order to confirm results. So for all of these reasons, at this time, the panel menu isn't all encompassing. And so it doesn't really replace conventional AST, but it's more, complementary to give you that information sooner if it's on the panel menu.
Yeah, and I like something that you mentioned because interestingly, not too long ago, I was asking someone from one of like a vendor, and I was curious because as you mentioned, like the panels out there, they're from gram negatives, and then the question came, okay, what about gram positives? And that's the answer that I got. It's like, well, it seems that right now with the genotypic information that the providers are getting, like, okay, I can have a treatment plan, if I, let's say, MEC-A for MRSA or VAN-A for VRE, and I can go with that. But there's that complexity when the gram negative rots that the need arises for have something like this. So it was just, it was interesting, learning about that and getting that information.
Yeah, and it definitely depends on your patient, right? The specific patient that's in front of you. What have the profiles been of their previous organisms that they've grown? What antibiotic therapy have they received in the recent past? What are their healthcare exposures, their risk factors for multi-drug resistant organisms? It's much more nuanced for gram negatives.
Definitely. Okay. So maybe let's, and as by now we have mentioned, your conventional AST, and right, so you have that time that you have to grow the organism, 18 to 20 hours, 18 to 24 hours, and then you put it in an instrument, and we have mentioned things, for example, like the Vitek, for example, which many labs use. You get, depending on the organism, right, gram negatives, you can get that susceptibility 8 hours, sometimes, gram positives more over 12. If you get on things like strep, it can be 20, 24 hours. So can we talk about how how the fast AST works, from isolate to the result?
Yeah, so actually, once your blood cultures are drawn, again, they're loaded onto the blood culture incubator that monitors for growth. And then once it flags as positive, you do a gram stain to see if it's a gram negative. And then once you confirm that, you can run that sample directly on your FAST AST platform. So you actually don't need an isolate in order to, run these tests. The only nuance there is that you might not need identification prior to setting up the FAST AST test, but you just need to confirm it before the results are reported. So that can be done in parallel or sequentially, depending on what your lab workflow ultimately ends up being. But you do need the identification at some point before the results are available.
Yes, and for some of the most common organisms that you see and blood cultures, many instruments out there, many different manufacturers that where you run that blood culture and you get that ID, but then yeah, if it's not there on the targets, then you have to kind of find another way to give that ID, right? So okay, and then how does this technology, how does it achieve those faster turnaround times?
So there are different technologies that can be used in these different platforms. I'll just give you one example. So, volatile organic compounds, or VOCs, are these tiny, easily evaporating molecules that are released by living things as metabolic byproducts. So it's basically like, the chemical scents of life that give everything from like pine trees to sourdough, their signature smell. And actually, early studies of VOCs came from perfume chemistry, so nothing to do with petri dishes or, AST testing at all. But in antimicrobial susceptibility testing, we can use sensors to track how a given organism's VOC breath changes when exposed to various concentrations of different antibiotics. And so this offers a fast way to tell if the bug will fight back or give up. And by doing so, we can determine an MIC and then, categorical interpretations based on that information. There are, other methodologies that are used as well by other platforms like time-lapse imaging, mass measurement, or morphokinetic cellular analysis. So it's very, very interesting, cool stuff that we're using to get this information faster.
Definitely very, very cool. And it always comes to mind that it just how much things have changed in the time. And I was mentioning this to someone else, before that. It's even myself that I've been doing this, some maybe like a decade or so, and I have seen so many changes. I can't even imagine someone doing 30 years and now they're seeing all these things that are coming. It's very, very cool, like the things that we are finding out and doing to ultimately help our patients. So right in the lab, we also think about things like equipment. We think about space, and we have seen some studies out there where they're doing some modification to the existing workup where they get some faster results, but without changing really equipment or anything. But when it comes to this, does it require any major workflow or instrumentation changes?
It does. So the lab will need to install a new piece of equipment, so there are definitely space considerations that will have to be made there. There's, the verification component of that, definitely IT integration, training of the staff that will be both setting up the test as well as, interpreting and releasing the results. Lab and stewardship workflow integration is really critical to ensure that really everything is streamlined and done in an efficient and timely manner. We know that, actionability is key. So labs will also need to establish a communication pathway, where the results of the test are reported to clinicians, whether that's a text or a page or some sort of alert in the EHR. And I think this is really, really important. It really highlights the collaboration between the lab and the antimicrobial stewardship program and the clinicians. That's really critical to maximize success of bringing on, a test like this.
We'll be right back. Hey there, micro friends. Are you enjoying this partnership series with bioMérieux? Well, I invite you to, after you listen to the episode, of course, to check out the show notes. There you can find some links with information about sepsis, antimicrobial stewardship, and more. Right there in the show notes for you. And now, back to the episode. Definitely. And now of course, with faster results and right, the patient can be put in the appropriate therapy, faster and contributing to the, enhancing a better outcome. And so when it comes to this fast AST, it's improving patient care, and how does it also improve, antimicrobial stewardship in real world settings?
Yeah, so there's been a growing body of evidence around this. I think we're still really, early in study of this, but I think we'll see more coming in the future. So far, we have, randomized controlled trials and observational studies that show a reduction in time to results, as well as improved antibiotic therapy for patients with bloodstream infections, whether that's escalation, time to effective therapy, de escalations, right, time to optimal therapy or narrowing therapy, and then even transitions of care. So, transitioning from an IV antibiotic to an oral antibiotic that we know facilitates patients getting out of the hospital sooner. And then there have also been observational studies that demonstrate a reduction in length of stay that's likely related to all, one or more of the above. I think it's really critical to note that in general, for a lot of the evidence that we have, we know that rapid infectious disease diagnostics should be paired, right, with antibiotic stewardship to really maximize this actionability and impact on antibiotic use and outcomes.
And maybe also as we're talking about this, maybe you can tell the listener about some like specific infections or scenarios where getting these results, it really makes a difference for clinicians and patients.
Yeah, so I think the clinical data and specific patient populations is, we're still learning a lot. However, it's thought that there might be particular benefit in, again, sepsis or critically ill patients, as I kind of mentioned earlier, patients with multi-drug resistant infections. So in situations where you're not as sure about what an effective antibiotic will be, patients with immunocompromising conditions where it's really critical to get the right antibiotics on sooner. Um, and then again, IV to PO conversion. So transitioning from IV to oral therapy for gram-negative bacteremia to transition patients from inpatient to discharge, I think will be interesting scenarios to evaluate further.
Yeah, definitely. And one thing that we have seen, right, is definitely that when it comes to we're getting these faster results, and we know that there's a very positive outcome of collaboration and communication, right? And I even did an episode not too long ago where stewardship team and the lab, collaborating together, and they give some examples. So very positive results when it comes from this, and by now you mentioned also, taking action, we touch on communication as well. So that's definitely very important. So when it comes to the lab and the stewardship teams working together, what can they do to interpret and act on those faster results that we're getting with this?
This is such an important question because it's just so important that we do this multidisciplinary work to really promote the success of bringing something like this on. And there's benefit in collaborating as early as the initial phases when you're even just deciding whether or not a test like this, a FAST AST, would be impactful for your specific institution and your specific patient population. Definitely when you're comparing performance versus standard of care, when you're looking at the panel menu, again, to make sure that it makes sense for your patients and what antibiotics that you're hoping to use. Workflow feasibility, so what patients to run the test on, what hours will this be run by the lab, what hours will the stewardship team be responding, how are you handling the limitations. So again, actionability is really key. I think, the diagnostic test itself doesn't really produce the intervention, right? So you actually really have to tie the labs and your stewardship programs or your clinicians together to establish an efficient communication pathway, maybe diagnostic or treatment algorithms, education and training. All of these things really would help promote timely and informed clinical decision making.
Yeah, very important, and and those things, and as someone that works on the bench, I think about that, and you mentioned training, definitely very important to kind of give a context to the audience. We do have some labs where we have people working on bacteriology, around the clock, but that's not the case for everyone. Maybe you have some labs where, yeah, blood cultures might be read, let's say, at night shift, but it's to the extent of doing the gram stain, calling that result, and then doing that, the initial molecular testing, and then reporting that. So now when it comes to having susceptibility results, then you really have to kind of start training that staff. Okay, this is what I'm getting, and then correlating that, make sure that it makes sense before you're reporting that. So definitely gonna take some training. And then that's not even to talk about labs that maybe, which I have seen this, that maybe they do micro like in first and second shift, and then people from the core lab, like chemistry and hematology, they keep an eye on the blood cultures. So that's definitely going to be some a challenge, and some training and figuring out if they're going to bring this in, how can we make sure that, right, we make it work, make it work right.
Yeah, and
So
I'll
that's
just
just
add, sorry to interrupt you, Luis. I'll just add, I think you bring up a really important point. I think it's not standard of care for most institutions right now to actively communicate phenotypic AST results back to the clinician, right? So typically, a positive blood culture might be called, or a gram stain result, or even a rapid molecular diagnostic test with identification. Those are starting to get called or paged, some sort of active communication to clinicians, but typically AST isn't on that. So that's certainly a practice change.
Indeed, yeah. And this is to another point, but and we talked about the changes, but as a microbiologist, it has to be such a cool time coming into the field when you're seeing this. And I would have been, and I'm still excited. And but I remember when I came in and just me seeing something like this. Oh my goodness, I would have been so excited to learning about this. So we touch on challenges, definitely training. That's one of them. We already alluded to the fact that it requires equipment and things like that, adjusting workflow. So what are the challenges, that you hear when it comes to implementing rapid ASD?
Yeah, so you touched on the workflow related challenges. I think in addition to staffing and training and like hours and all of that, the clinical response, what method will be used for identification? So it's really, if we're hoping to really optimize our time to results, then it really benefits the whole workflow to have a rapid identification method as well. So, what is the method of identification that will be utilized with the FAST AST? Because we know that information is needed prior to reporting the AST results. And then I think another big thing is cost justification, right? So there's still a growing body of evidence to demonstrate the clinical utility of these tests, but it's still relatively new. And so justifying the cost of bringing something like this on, given it's complementary and not replacing a test, is something to consider as well.
Yeah, and before we jump to the next section, and this is something that I shared before, and it's just from my, of course, I'm anything that improves the outcome of our patients, and technology is great when it comes to that, and we're, even with things like MALDI, we're bringing ID so much faster nowadays. Now gene sequencing it's coming into play, and we're doing that too, and so many things that we're doing that ultimately, they better the outcome of our patients. But as a tech, working on the bench, I think for me, the biggest one of the challenges is going to be wrapping my brain around the fact that you're putting a result out there. Yeah, you have your ID, right? And you have your maybe before your plate has grown up, right? So it's like having that before we had that comfort of knowing, okay, even doing that direct blood, you see it, let's say on the Vitek, and then you, as I mentioned earlier, you're looking at your plate, okay, the first molecular test and identify, okay, Klebsiella pneumoniae detected on a CTXM. It makes sense. You don't have any SBL here. Everything matches. My plate is pure. So that's the only thing that for me, it might take a little bit to adjust it. We have to adjust our process. But then again, things change and we can do that. I even remember when we brought Maldi on, adjusting your brain and your workflow, was a little challenging now knowing that you had that answer. So sometimes you even work backwards because you're trying to find out what I have and then tailor the workup according to that. So we get through them. It's just one thing that I just wanted to mention. So as far as looking ahead, how do you see this fast ASD evolving over the next few years?
I think it'll be really interesting to see where it goes. I know one area is really increasing the bug drug combinations that are currently available on commercial panels. So filling the gaps that we know currently exist, maybe expanding more into gram positives, into yeast. There's also been some interest in testing other sample types. So up until this point, I've only been referring to the use of fast AST and bloodstream infections, but there's some interest in fast phenotypic susceptibility in urine samples or respiratory samples, CSF. The opportunities are endless when you kind of think about all the different sample types that you could use. And then I think the most exciting part is this growing body of evidence that I think we're going to see over the next few years as we have more widespread adoption and some clear evidence on how these tests are best utilized, where they're making the biggest impact. I think there's going to be a lot of learning in that area too.
Yeah, and besides that, if by now, if people are listening to this and they're kind of hearing about some of the challenges and things like that, so what advice will you have to offer for a lab or a clinician that was considering adopting, a faster AST method?
I think one of the biggest things is really this multidisciplinary collaboration. I know we've kind of alluded to this, but it's really, really critical to ensure workflow optimization. So I think that is absolutely key. One thing I didn't mention earlier is, these tests also can't be used on polymicrobial samples. So there's just a lot of nuances, right, that need to be worked through there. I think it'd be really helpful to really review your institution's internal data to really give you an idea of where you think you might make the most significant impact of, a faster result. And if you bring it on, it'd be great to measure this impact, right? And then sharing your experience with others. Again, this is a relatively new space, so any opportunity that there is to learn from other institutions that are tackling this presents a really good opportunity to learn from each other. And then I will say, the manufacturers are really supportive. There's many, many dedicated individuals that are working in this space that have a wealth of knowledge that they can share. So, establish those contacts with the manufacturer and, reach out if there's anything that they can support you with.
Yeah, yeah, definitely. There's like email listservs, where people ask their questions, and then also many people that are constantly, publishing, and they're an email away if you don't have an initial contact with them, and that's how you start things. And hey, I'm from this institution, send them an email. People are wonderful. They will reply. They will help you out. So we all want to help each other. So that's a great way. The same thing if you go to conferences and you see someone presenting on this or see vendors, talk to them. And as you said, create those contacts. It's very important. And definitely, yes, communication. It's and I like the fact that you brought the polymicrobial. That's something, to keep in mind because we've been talking about how this works. But yeah, in that case, as of right now, if you get different morphologies in your gram stain, then you have to proceed with your traditional method where plate it and then after that isolate your colonies and then perform susceptibility testing appropriate. Well, as we kind of close, as the episode comes to an end, are there any closing thoughts that you have about this, Sonali?
No, I think that was great, Louise. I'm really excited to share this information, and I think if there's anything that I can, hope an audience takes away, it's the collaboration that's so critical for lab and clinicians. I think that's really the key to success here.
Indeed. Well, as I said before, it was great having you back on, and thank you for taking the time. This was great, and I hope for the audience that you enjoy this. And also, if you haven't had a chance, maybe this is your first time listening to the podcast. So go back, there's 2 episodes. We're tying this thing together. As I mentioned before, we started with an evolution of AST, talk about molecular diagnostics, and now we're on FAST AST. So I hope you enjoy this information. Well, Sonali, what a pleasure. So thank you again for taking the time to be in Let's Talk Micro.
Yeah, thanks, Louise. Thanks so much for having me again.
My pleasure. Well, there you have it. I hope you enjoyed this episode. And right, isn't this such a fascinating topic, fast AST and how quickly those results are produced, right? And we talked about traditional cultures where you have to grow the organism on a plate and then do the susceptibility, but here you can do it directly from the sample. So it is just a fascinating topic. So I really hope you enjoy this episode. Okay, so as always, you can find us on any podcast platform, right? So if you go to Apple, Spotify, Amazon Music, Good Pods, you can find Let's Talk Micro. So I invite you to subscribe to the podcast, download episodes, and if the app allows you to do so, please leave a review. Thank you so much for the support. As far as socials, you can find us on Instagram, TikTok, YouTube, and Blue Sky Social as Let's Talk Micro, on X as Let's Talk Micro 1, LinkedIn as Luis Plaza. There's an email address which is letstalkmicro@outlook.com, and there's also the website letstalkmicro.com. And in the website you can find resources such as certification tools, study tools, episode updates, and more. So I invite you to subscribe to that as well. If you want to support us in any way, you can do so via Venmo or via Buy Me a Coffee KOFI, and both links are available on the show notes. And if you are looking to learn more about antibiotics, please check out www.learnantibiotics.com and the Learn Antibiotics book available on Amazon. These resources include cheat sheets, practice tests, games, and more, and they are being used by thousands of people worldwide and may be helpful for you or your colleagues. As always, these are some great resources from Dr. Timothy Gauthier, a very passionate pharmacist. And as you know, the Let's Talk Micro podcast is supported by the American Society for Microbiology. To learn more about microbes, visit asm.org. And that, my dear friends, it's the end of this episode. I hope you enjoy learning about FAST AST. As always, I enjoy sharing this information with you. Such a great topic, and the potential of this, right? It's so amazing. So I hope you enjoyed it, and please check out the other episodes of the series in a partnership with bioMérieux. As always, thank you for the support. Thank you for listening, for downloading episodes. Stay tuned, great things coming your way. And please, continue bringing that passion to what you do. It's so important. You do such great work. So, as always, stay motivated, stay safe, and of course, continue talking micro. Until the next time. Bye.